Right. Good morning, everyone. Shall we make a start? I'm Swapna Alexander. I'm a geriatrician in North Wales. I don't know any of you because obviously I'm assuming all of you are from South Wales, so everyone is new to me except a few people. But this workshop is really a free for all. So it's a kind of discussion, question and answer, information gathering, networking, etc. So can I just ask how many of you are already working in an FLS? Because I gather everyone doesn't have an FLS in South Wales. Is anyone working already?
Half and half. Within a little bit.
What does half mean? Okay, you're in the service.
So I often give his resolves in the community. I do a lot of forward work in the community and then linking the FLS database if I've started somebody on osteoporosis treatment.
Okay, so you're a contributor. No, it's anyone part of an FLS service already existing? Fracture liaison service.
Oh yeah, we integrate with the full service.
Okay. No, but are you linked to the fracture liaison service, like identification and treatment management? So you're all components of the service, but not actually under the umbrella of FLS. So I'm sure all of you are working in some.
I've joined the FLS group, which obviously was set up as a GP side.
Are you a GP?
I am. I used
Fantastic.
To be a GP.
Even better. So you've got all the components needed.
So that's why I offered myself.
Well, you're the ideal candidate. No, as you can see, everybody's doing the work related to FLS. Now, somebody was asking, what is the FLS? Now, obviously, there are many components to the FLS, but basically it means identifying patients who have had sustained fractures, identifying and making a proper plan, like making a plan of either diagnosis, management, treatment, and follow-up of these patients who have sustained fractures. Now, we usually, when we say fractures, we mean fractures over the age of 50. Under the age of 50 are very select. So when we are talking loosely, we mean patients over the age of 50. Now, the idea is obviously to target all these people. So in order to prevent a further fracture, to prevent further morbidity and mortality. Now, the fracture is huge. You can imagine identifying these patients are a huge task because they come from all walks of life. They may be in hospital, they may be abroad somewhere fallen down, they may be outpatient, inpatient, etc. Each hospital has got different systems of identifying these. They come through fracture clinics, some come through SDEC. We've gone through the whole gamut of things. So identification is a big problem. Identification, diagnosis. Now, once you identify these patients, you need to have a proper plan of action, what to do with them. So identification, management, whether you want to scan them, you want to treat them, you want to bring them to clinic, what kind of people they are. Treatment is another huge issue. These are the main headings. Obviously, there's so many subdivisions of each thing. Treatment is a huge issue. Number one, do they need treatment? Or, prescribing the right treatment, informing the GP, informing patient, follow-up, compliance, etc. is a huge issue. And then the main follow-up of treatment, etc. Follow-up in terms of treatment, in terms of falls prevention, in terms of fracture prevention, etc., bone health, etc. So it's a huge outlay. That's why I'm saying all of you are doing work in different aspects, but unless they're all under one umbrella, we don't know. The patient doesn't go into the journey as they should have gone. Because I'm sure, as you mentioned your falls prevention, you work in that. Now the question is, number one, fractures. How do you prevent fractures? Do you look at patients' bone health? Do you look at their falls? I'm sure you're starting to look at it, but it needs to be done in a more formalized manner, which is what the purpose of the FLS is.
I know the service concepts in my way of identify how patients follow with a fracture.
Yes.
From radiology, and then they get referred to the fall.
Yeah, so some places they get referred to the falls, some places they get referred to the FLS. The FLS should contain the falls program as part of the deal itself. So. Signpost. No, but I'm saying the pathway is more vast than just treating the acute problem, and that's the whole thing. And I think, I'm just saying for us, our service has been in existence in 2006, so it's a long time. And it started, the business plan and so on was written well before my time. I started in 2006, and somebody's hard work did all the business plan for us, and thought about, incorporating so we have huge numbers of people in that, not huge numbers, huge specialists in our team. We obviously have a fracture liaison service nurse. There are 2 nurses, but who are also specialized in osteoporosis, because obviously that's the next North Wales. North Wales. Sorry, I'm North Wales. That's why I'm saying it may not really apply to your thing, but it's the same principle.
Because we never, I don't know, Kathleen will know better than I'm Dr. We never to any fracture.
Oh, I do sometimes refer back to Linda. Yeah, I refer back to Linda.
No,
some of them, but some of
yeah.
them I start the treatment and then I refer.
Yeah, no, but
refer on
the
to
problem
follow-up.
is patients should not be picked up just because you had an interest. Every patient should have a uniform, access to uniform level of care, not because you had an interest. You are interested in falls, so you look at the falls aspect of things. You are interested in treatment, so you might look at. I'm just saying we all look at different things, but unless you're part of the system.
Having a fragility factor in your area, you can see it. And you're not seeing some.
The idea is all of them should be assessed by the service. So in order to get the optimal care to prevent the next fracture, because obviously fracture has happened, I'm assuming anyone with a fracture is getting orthopedic care. I'm sure that's the standard. But apart from that, the idea is to prevent further fractures from happening. So that is the important issue of fracture liaison service. I think one of the things we didn't consider so much when we started the fracture liaison service, we were more interested in identification, diagnosis, treatment, etc. But we didn't realize treatment would kind of take over our whole life, because treatments, organizing treatments and so on does take a lot of work, running up patients, blood tests and so on. So now we are kind of bogged down with other things. So when you people are thinking about starting a service, I think treatment was a huge thing that we made a mistake about in terms of not investing in staff and personnel. And I don't think money was the problem. It was just the staff that we didn't think about. And that was one of the failings of our business case in the beginning. And the other thing is links with other services, very, very important. Other services, the part of the FLS will obviously be with orthogeriatricians, fall services, bone health, osteoporosis services. But other services we need to link to is obviously the orthopedic surgeons, in order for them to identify and refer. I get so many referrals now to orthopedic surgeons because they're all on the ball, and sometimes they over-refer, but that's a different matter. But I'm saying all these people are on the ball. So orthopedic surgeons, radiologists, very, very important, because they can identify, especially things like vertebral fractures and so on, they can identify and let us know. And the other problem with radiologists, I must say, you have to have good relations with radiologists, because they report x-rays in very odd fashions, especially vertebral fractures, possible wedge, possible compression, there are so many possibles, suggestive of, etc. So unless you maintain these links, so I'm saying you do have to form links with other people for different reasons. And I find, the biggest issue is the radiologist. So, that's an ongoing issue. The radiologists, we have plenty, and they come and go, and different people report. So it's an ongoing audit situation for vertebral fracture. I don't know if anyone has problems identifying vertebral fractures. Yeah.
So when they fall, they come to us and we have possibilities of x-rays and I have linked with Usman. So when I see that, I can ask him to look at it and give me the expert opinion. And then that's why we set up that thing on our unit. She's leading a who give this phosphonates and vasculature of the Usman uses our service. So you can see we are.
No, you're slowly getting there. Yeah, you're working silos, and as I say, only the few patients who attend your services get the care. So there's so many people around the place who are probably not getting the care they should. So identification is the hugest problem. I mean, we have so many, every time we have to keep on refining the way we identify patients, because, you assume you got it right, and then suddenly you discover a new consultant has arrived and admits patients to some other ward rather than into the normal ward, which you expect. So it's a permanent, we have to keep on asking how on earth patients get admitted and, how patients attend clinics, because our main source of things, either x-rays, fracture clinics, and inpatient fractures. So it's a permanent story about how we get it. But now we've raised awareness with the radiologist. So anyone, it's a pain sometimes, but anyone with a vertebral fracture, automatically the report comes out as, if the patient has not been investigated before, please refer to the bone unit. So we get these patients, whether they're all new fractures, they get automatically referred. So it has increased our workload tremendously, but these patients are getting picked up. So that is good. So main thing is raising awareness and raising enthusiasm and interest, I think, because if people know you're doing something, they will continue to refer, and they will continue to, because they realize everyone knows the benefit. I don't think anyone has a problem realizing the benefits of the FLS. That's not what we're here to argue about. It is how they engage with it. And I think that's the success of our service is everybody engaging. The GPs are extremely proactive, and they are very on the ball. They refer their fractures themselves, because patients come from somewhere else or some other county or someone somewhere else. They refer automatically. Treatments, they're very much on the ball. They usually write and ask us, is there a, can I ask, there is a, what's the word, best practice tariff? No, what is it called in Wales? Cough. For patients on treatment with fracture. Was there not something?
No, I'm not aware of.
Okay, all fractures should have been identified from the GP perspective. So they are very much on the ball. And pharmacists are very much on the ball in GP surgery, because they review all patients on bisphosphonates. They refer back if patients are, been so many years on bisphosphonates. So everyone is like part of the deal, but it has taken many years. It didn't occur overnight.
The problem seems to be a lot of communication gaps.
Yes.
So, for example, we don't know if fracture clinic has picked up on a fracture. Have they started the ball rolling, or are we going to start the ball rolling? That's just one example. I do something called a lateral hip vein clinic, and a lot of people also have back issues. So one of my first job is to read that out. And the number of times I'm seeing scans which have been requested. The problem is this is pathway driven, and people fall through holes and stuff.
Yes.
And the number of times people have had scans requested somewhere further up in the pathway, nobody's actually seen it. So the lady has actually got a couple of osteoporotic fractures and is quite osteopenic, but nobody's actually then taken the step.
No, but see, that's why if you have a service, the GPs don't care. If they see a fracture, they just refer. The radiologists simply write on the things, please refer. So these patients just land on our plate.
These scans have not been requested by the GP.
No, I'm saying whoever it appears on. No. So it's written on the scan, please refer to the unit. So whoever is the referring person, it's their responsibility. If they don't, that's a different matter, but the responsibility is on them. So everyone is there to pick up. And if you're in doubt, just refer. But if you don't have a service, obviously the question is, who do you refer to?
Because who's taking the responsibility? We need to have guidance. So if we see this, right?
Yeah.
Okay, this thing, these are the things.
Yeah, no, that's why you need to have the service, because service will decide whether it is for us or not.
So my question always is, when a radiologist is reporting it, can't they trigger the referral?
No, but the clinician has requested the X-ray. So it's the clinician's responsibility to refer on, not the radiologist.
Yeah.
Radiologists can only recommend.
But the point is the clinician has requested the scan,
Yeah.
the X-ray for something else.
Yeah.
Usually the ones I see, not with osteoporosis. But quite often there's osteoporosis there which is untreated, untapped. So at the end of the day, my question always is the radiologist is also a clinician. Why can't you make them take that next step? If they're actually reporting on something, either having a system of highlighting it, because everybody gets familiar.
No, they do highlight.
The problem is that there's something breaks which be that in the spine.
Yeah.
It's a lot of the nurses see the plastic.
Yeah.
Somebody else's.
Yeah.
The patients had 6 opportunities to be
Honest.
No, but I think it's raising awareness. That's the bottom line. Because, end of the day, it's always like, oh, this is not an acute problem. Patients come to me for something else. So let's leave it for somebody else. That should not be the case. Everyone should be aware, and it's everyone's responsibility. That's the bottom line. Thank you.
Welcome everyone. So just introduction very briefly, I'm Peter Carr. I'm the Executive Director of Therapies and Health Science in an Aaron Bevan University Health Board. So I'm one of those mysterious exec directors that sits on the board. You've done a huge amount of work on some business case or case, ideally in this context for a fracture liaison service, who knows? And we're very much your audience at the very end of that journey in a way. We're the ones who might accept it, reject it, approve it, get you the money, or even send you away to do more work on it, you know. So the benefit really of trying to get in my head, so you can understand what are the things I'm looking for, or my colleagues on the board. And we are all looking for slightly different things depending on what our portfolio is. But if I can help you with some of that, to try and think what's in my head, what am I looking for when a case comes our way, so that you are thinking of that right from the start of the journey. You don't want to know about that or learn about that when you're in the board meeting presenting it to us. It's too late then, isn't it, really? Because we're just sending you away to do more work on it. I think there's all sorts of things in there, and you might have some questions. If I just share with you a few of them initially, and that might stimulate some questions that you've got as well about the kind of things that we're looking for. I think one important thing to do is really make sure you're clear on the benefits that the development, the case, the new service, whatever it is, will deliver. And it's not just about the obvious benefits, the benefits to the individual in terms of their actual outcomes, their experience, how it will improve their life, but it's also the benefits to the wider system. So, you know, I hate to talk about the subject of money, you know, but it is there. But there are huge benefits if we improve care for people, if we improve outcomes for people and experience, then money does fall out of that. It genuinely does. And if you can describe that and how that looks, that's really important for an organisation, particularly if you're asking a board to invest in something. If you can demonstrate that actually you will gain more than that investment back, and you can describe that, then that becomes very attractive. When you've got something that's in the area of community-based services, prevention, working upstream, it's really hard to describe that payback in a tangible sense. Money very rarely falls in a nice neat pile on your table when you've done something. It's hidden in the system somewhere. The financial benefits hidden in the system. From a board point of view, I would just say to you, that doesn't matter in a way. I think people worry about that. If I'm building a case, it's a bit of an investor safe case, how can I show the execs that they'll get their hands on the money? You don't have to. If you can demonstrate that the broader system benefits, we understand that's very often the case with primary care, community-based services that are working upstream on prevention and that kind of thing. We know that. We know you won't get your hands on the money in that way. So don't worry, don't get bogged down by that, but do try to describe what some of those financial benefits would be that you would expect to see in a wider system. A spend to save scheme is not necessarily about you needing to pay it back yourself. That makes sense, okay? The value you'll get out of doing something and the benefits are really important. So like I say, it's not just about the money, it is all about the outcomes and the experience that we extract from doing these kind of things. I think the thing to tune into is we're health boards, we're not health trusts, okay? And that is important difference, because from a health board point of view, day to day, we're thinking, how do we fulfill our purpose as a health board? And what that means is we're really focused on population need. What's the need of our population? We're not a trust. A trust delivers services we're commissioned to deliver, in which case you'd be bothered about, can we deliver this service? How much activity can we get through? Have we got the capacity? And we'd get bogged down by all that stuff, which is important if you're a trust. It's important for us as well, but probably more importantly for us as a health board is, are we responding to the needs of our population? And if you can make that argument, you are pressing our buttons. Okay, that is really important, because we are scratching our heads on a daily basis about, worrying, are we meeting the needs of our population? How well are we doing that? How effective are we at that? And that is a very powerful element of your case, is the population benefits. So do tune into that and try to describe that. It does matter to us in a way it probably wouldn't matter to a health trust. As a health board, we're really interested in that element. one more thing I'll just share with you, and I'll let you kind of ask me some questions then, is evaluation is really important. So any kind of new service development or scheme or whatever it is you're putting forward and you're trying to make a case for, you must describe how you will evaluate it. What does that look like? Where will you get your data and evidence from? What will you do with that data and evidence? So what is your plan around that evaluation? What's the so what bit? Will you run this new service on this development in the form of PDSA cycles so you can make adjustments? If it didn't work, how would you change it or end it? You know, so evaluation is really important. If you don't describe that in a case, we wouldn't really accept it. We'd send you away and ask you to describe that. But importantly, it's not just giving confidence that you will evaluate it, but what would you do with that evaluation? What difference does it make to the way you would run the service? So evaluation is super important, really. There are so many cases come our way as a board that don't describe the evaluation piece. So they're just a few things in my mind that I'm kind of looking for. There probably are, there are loads of other things as well. You might have some questions as well that you're thinking, what do they want? Is there anything that you'd just like to ask me? Or yeah, it is. Yes, thank you. Yeah, very different. Yeah, so that trust health board difference, looking at it through a different lens. Yeah, absolutely. Yeah.
I same note because I work for the current government and now when you said this, I had flashbacks of me presenting to the board SLT last year.
Yeah.
So I did my best in my business case, and I touched on most of what you told me, but it wasn't enough.
Yes.
So now, and then because I'm a geriatrician and consultant, and when we were training, we were very good learning about clinical stuff.
Sure.
Never management. And on top of that, how to, about the business case, I never sat in as a trainee to say, they told us it's the basic stuff, which we all know. But the way you look at it, I still don't understand.
Yeah, sure. So thank you for that question. For the benefit of the audience online, just kind of, it's very difficult if you're a clinician to understand what those other aspects are that the board is looking for. You will look at it from through clinical eyes, of course you will. I would say never ever develop a case on your own. Work in a team. So clinicians work with managers, work with workforce colleagues, work with accountants and finance colleagues. And the benefit of the workshop today is you will meet some of these people and they'll advise you about those different aspects that you need to be thinking about in a case. From day one, when you're starting a case, don't start on your own. Start as a bit of a team and work together with finance colleagues, with the workforce colleagues, because you'll only look at it through your lens, and that's entirely understandable and appropriate. Collectively, you'll cover all bases. You really will. So do a team approach. Yeah.
I wrote it and I send it to everyone of you, the finance person, everyone. I ticked all the boxes.
Sure.
But I think maybe I did a basic mistake by not putting them at the start.
Yes.
That's my learning.
Yeah. Another thing I would advise as well, before you present to the board, rehearse it. Do almost like a pretend board. Think of people who get to try and get a board perspective. And as an exec director, if anybody ever contacted me and said, look, I'm presenting a case to the board next month, I couldn't run it past you in advance, could I? I would absolutely say yes. Let's spend an hour going through it. Do ask as board members. We're very approachable. We would happily spend time with you and do a bit of a dress rehearsal or whatever. Because
remember your name.
please do. Absolutely. Yeah. At the back.
We are hitting the right buttons. There is invest to save. There is a business plan. There is a cost saving, invest to save, but it's not being approved and looked at by very senior management. Top management.
Yeah.
They say they have 200 business cases in front of them whom they will choose. But this is quite straightforward. Low investment and it's for savings.
Absolutely, yeah.
You reduce any attendances, you reduce the burden, social care, health care, hundreds of benefits, all research proved. evidence is there in the literature. So why management, senior management won't look at the literature? And there are some monies.
I'm afraid that's time, ladies and
There are some monies
gentlemen.
being put into some other services which have benefits.
Absolutely, yes. No, I can understand that frustration and that misunderstanding about why sometimes that are just blindingly obvious, what I would call just do it, why it's so hard work to get something over the line and you have to go through this long bureaucratic process. There's something about the start of the journey. If you could describe it as a just do it, there's clear benefits. Don't go down that big long road of a big complicated business case. If you can package it up as a just do it and get it to your divisional team, don't even think of the board and make that argument, you might be able to get it over the line that way. I think sometimes we get sucked into an idea we've got to do big long business cases, and actually management teams will be receptive to just do it. The other thing is you must have it incorporated in the organisational plan. You won't deliver something if the organisation's plan hasn't already identified it as a priority. So that's really important. Thank you for your time.
Hi everyone, I'm Roxana Williams. I was Directorate Manager for Care of the Elderly Services at An Bevan. I'm now the ED Manager at An Bevan. I worked with Indusing to set up the nurse-led bone health service. It came at a time where we had some funding available for COVID recovery. So our waiting lists at the time for care of the elderly patients were at 55 weeks. And I worked with INDA to identify what we could do to improve that position. And one of the things we came up with was a nurse-led bone health service. So since we've implemented that, our waiting lists have gone down from 55 weeks to 17 weeks. And it's been working really well. There's been some ups and downs, but so far it's working well, and we've got some really good feedback from patients. So this is kind of an interactive session. Are any of you thinking about setting up an FLS service? I can recognise a couple of faces, so I know that maybe I hear, maybe not, but around anyone thinking about setting up a service or needs any support, any questions around the business case process? No? That's fine.
I do a little bit of phone health. So I work for rapid response team.
Sorry, say that again.
I work for the rapid response.
Rapid response, okay.
Yeah, and we integrate with the Falls service. So our role is providing treatments on behalf of the Falls. So it is quite a new service. We have a huge backlog on the COVID. Like we should have this one out there. And it took us 12 months to clear the caseload.
So you were working on more of the community element of the
there have been 2 new nurses that have been integrated into the full service that have integrated into Rapid as well, providing the services. So there was funding brought in for the nurses to support both teams. But it seems to be going quite well. But obviously there's few grey areas as well on who can actually have the treatment as well, depending on the clinical frailty scale. So, I mean, in the future, I can see the service moving forward and going into the community, treating people in their own homes.
Yeah.
Instead of the clinic. But that will take funding, the business case will have to go through for that. I know.
But I think
this is the problem. We haven't got the resources.
Alison is my team lead.
Okay.
Working as the team lead for 1 CRT. Now we went to this man, Dr. Mohammed, saying, can I have the bone health services to us, because we have a unit and we have a clinical area. We need to produce numbers so that we can reach, rather than going all of them to Neville Hall, the 2-1 patient can come to us.
Yeah.
And that's how we started. And she led that back. So all the 2-1 patients, rather than going to Neville Hall, come to us. But the problem that we didn't recognize is the impact of that to our gender workflows.
Yeah.
So when you are doing that, I think you need to help Alison in the long run, because we are really struggling at the moment. She's taking all the responsibility out and then try to train the false nurses. On top of that, maintain this caseload, the spreadsheet of patients for next 3 years. because when we started one, we had.
So you need to look at the
Exactly.
spreadsheets over there.
Yeah, so these ladies, they keep all of the
So this is for
spreadsheets, they do all the admin.
Oh, I just emailed Jane.
I'm sorry, I'm going to stop my.
But no, I
talking
absolutely,
because I'm fine.
Priya, I absolutely agree
I
with
mean,
you.
the
That
issue
is
is
the
what you've
future.
got on the board is
Yeah.
some of the duplication. So,
Yeah,
so a lot of my
It's
forwards work,
duplicate,
I end up
yeah.
emailing saying, oh, they're on this waiting list, take them off. We've seen them in Falls. I've started their bone treatment. They don't need to go to a clinic. They just need to follow.
yeah, I
It's
think we do need to
communication.
try to let them know, don't we?
And we do
Yeah.
a lot of that under the radar, which is the issue because we're a small team.
Because the patients love our unit because we allocate a nurse when they come, we see them. Now this is for blood transfusions and infusions and for denosumab and but the thing is, lot of people go new and we work in cycles. There's lots of
Yeah.
communication, and the impact with the other work is huge now.
I think what you're describing, Priya, and just for those who don't know,
Yeah.
so obviously Priya works in the community, and this service is in secondary care within an Iron Bevan. I think there are definitely opportunities for joining this up. And I've got to be honest with you, when we set this up, I didn't even know that existed until you've just told me. So I didn't know, yeah, and we work in the same health board, so I think it probably is absolutely. So there is definitely scope to improve that. I'm not in the service anymore, Priya, but I will pass this over to my predecessor because I think, yeah, there is absolutely, key opportunity for working with the community.
This is other services where we started quite small.
Yeah, and now it's
like one or two
picking up.
infusions a week. All of a sudden, there's a huge recognition of the needs of these treatment, and the list of just going longer and longer.
Yeah.
And resources need to be put into place to support.
I think if it's duplication,
Yeah.
then you just need to email
Yeah.
us and all the admin teams that you work with on the secretaries to say, is this person on your list? Do they need to be seen by us? And then that way we can.
Do you
find
have an
out, yeah.
admin function then? So how do you manage that patient workload?
We've got.
You have got
We
admin.
got admin, but that they do all the other stuff as well.
Yeah.
And the other thing is Dr. Sunil is our Joe Winehouse consultant who leads the bone health in Ireland. So that's why I know him, how it came to us. But I think he's the lead person to get Alison involved in whatever
Yeah.
things and
Okay. We'll have a chat.
Yeah.
Let's have a chat in the break and just see what we can do about that, because that's exactly where we need to go, isn't it? Treating patients in their own home, in the community, so they don't need to come into hospital.
Of us going to nursing homes and do them, because I had so many requests like that. I said no, because they don't have the capacity to go there and spend half an hour and then arrest cases. So and even the does that sometimes in happily, but I refuse so many times because we don't have the capacity.
Yeah. Okay. We will have a chat. I'm just going to bring the discussions to the front row and just ask. So, wow.
Yeah, it's just interesting. I was going to bring a curveball in there, really, or certainly around duplication and workload, etc. Because essentially, say last year we saw 140,000 people 65 or over responding calls within an Iron Bevan. 60% of those are going to be falls related, 75 plus potential. Looking about 1,000 plus patients we've seen that potentially be screened for preventative secondary fracture. So the ones that we lost there for less through primary fracture and then missed to follow up an actual intervention. So there is scope potentially for us to use a FRAX or some sort of screening tool to identify those patients, but then how we would link into the existing service without overburdening what you already described with the community. Sounds like you don't want to be getting that 600 referrals for potential.
We get quite a lot of your referral then.
You get some referrals potentially.
Sure. So I think it is about that coordination, isn't it? And there's probably, we need to sit down, all of us, and just describe what services we've all got in our areas and how we can bring those together.
And I think the difficulty is, isn't it? So you've got the patients that have fallen fractured, and then Rob on the Priya probably seeing our forward with things are those that are falling and the then sees in mass that are falling that haven't yet fractured. They should be on treatment, and especially if they sit under, because that's what lots of my emails to Jane are. I've seen someone who's got high fracture and started on treatment, she needs follow up. So it's whether that all sits, does that all sit under FLS when we're saying it's a fracture liaison service?
Yeah.
If it's non-fractured, I'm thinking, well, it could go on to a normal clinic for a virtual phone call. Would virtual be any good for some of your patients?
A lot of my falls patients are virtual physio, and not necessarily me. But it's where they also, you know, that's, you know, if I sent all of my group to you,
That's difficulty.
It would,
Yeah,
the
it would
expansion
explode,
would be
wouldn't it?
massive.
Well, is it worth having an MDT with the FLS and yourselves once a month or once a week, maybe, and identify the patients?
I start all my patients, I fax them all as they come through Falls MDT.
Yeah.
Is how we work in Caerphilly.
It's the same when it comes to secondary care, isn't it?
Yeah.
Because if they are a hip fracture,
they're done.
lucky at the end of a hip fracture team. If they're a wrist fracture or maybe a not a fracture, they may get lost.
It definitely feels like there's something that we need to do, isn't it? And through this discussion, I'm going to put that as one of the actions about how we all work together to bring this service into one.
And then I think there were patients who came for different reasons, but fallen at home. We know it's a factor. They don't want to do it. So they asked me, can you do X-ray for me? It's not simply me doing the X-ray. I'm not an expert of, and the reporting it doesn't take immediately. And you know, I do my problems myself. So, and then the fracture clinics, and then sometimes they don't want to go for fracture clinics. You know, this is the kind of problem sometimes.
Yeah.
I don't want to.
Okay. Yeah. Well, we'll put that as an action, and I'm sure Inda would be really keen to have a chat with WASP, you know, community, etc. Yeah,
More and more
sounds good.
patients are staying in the community and telling us to look after them.
Yeah.
They don't want to go. They make informed choices now not to go. So we need to put attention to the community now.
Right, so we got our 1 minute warning. Anything from the back row that that you wanted to bring forward for discussion? No? Okie doke. No, not at all. Not at all. It's all relevant, isn't it?
Sorry, I'm just really interested in the discussion about the linking policies, particularly with patients who haven't fractured and who go on to treatment. So we obviously we did a report last year for fracture liaison services and the gaps inside. And one of the big things that we've really discovered is the value in the service is because patients on treatment, you know, and those regular follow-ups. So, you know, if I sort of guidance and so on, that element consider looking at how you bring the service together.
Yeah. What I would say during the break, our bone health nurses, they've got a stand, and they talk to them about that as well, because they're doing a lot of health promotion as well, and there's probably you know, more that we could do around that. But yeah, definitely have a chat with them. Thank you. Okay, thanks.
Okay, if we can stop there. Sorry.
Thank you.
Morning all. I'm Karen Archer. I'm the finance business partner working in the Nairn Bevan, and I work for, or I work supporting the medicine divisions and the urgent care divisions.
I'm Sam Abraham. I'm Assistant Medical Director for Community and Specialist Medicine in Wrexham, USP. I'm here in a supporting role with Karen.
So the purpose, I think, for this session of this morning's session is I've worked closely with Dr. Singh and his team around developing the business case for the FLS service within an Nairn Bevan. But we both strongly feel without that collaborative working across the different professions, whether or not we would have had the same success. So it's about sharing really, how do we get that success, get the right people to listen, to become as passionate as the clinicians about the service and development. So just a bit of background really, you know, traditional finance, a lot of people say, well, what's the purpose of finance in NHS? No, we don't need them. We're here for patients. But, and possibly traditional finance back office function, you know, making sure that we're in control of the money, we're doing the right reports accurately to Welsh Government. But the modern approach is around business partnering. And I would guess most health boards, if not all, that you work in have got a business partnering function of some description. And a lot of that is about us myself included, working directly with the services. We're aligned to divisions and directorates, and we're actually working alongside those services so that we understand the services, we understand where the resources are going. It's not to be big brother and challenge and question. It is about being a critical friend and doing things collectively. So really that's the context. So to give some ideas really of how I've worked with Dr. Singh around this project, having a corporate function, working directly with the services. I was aware that Dr. Singh had this desire, this passion around the FLS service, needed an element of investment. We needed to build a case, which we were working on. But whilst in my corporate role, I became aware of funding to be bid against. There was a small level of investment, and this actual service needed a very small investment to run a pilot project over a period of time, just to get that proof of concept. And I think sometimes by doing that proof of concept and analysing that case for change to the execs, that's how we get that assurance really that this is the right way forward for our patient cohort. I was confident when that investment came in that this service was hit the criteria that we could bid about it. If I didn't work closely with the services, that money would have come in, others would have had the chance of it, and this FLS service potentially would not have featured in that. But I work closely with the service, we could do that. So there's definitely benefits. So the key start on this really is data and evidence. Knowing why do we want to make a change? Why do we want to build that business case? So data was everything. We had to get that firm baseline right. As you all know, in NHS, we're drowning in data, the sources of data from all sorts. What sort of data did we need? Ultimately, we needed to be able to measure the outcome for the patients was going to improve, or there was something within our current pathways that wasn't working for that patient that we had to identify. So what we set about doing was some resource mapping right across the current or the previous now patient pathway in terms of what happened to those patients and the return to ED with similar conditions, falls, and potentially a fracture. So it was then measuring what did we want from the new service? How were we going to measure that the input of the clinical nurse specialists, what impact could they have on that patient cohort? And then we measured, or we tried to map out the patient pathway that would look like. And you could see some quite big changes within those pathways that in theory at that time was demonstrating the benefits primarily to the patient, lots of benefits to staff, because we were still trying to run a service with staff groups potentially hard to recruit anyway. So these patients perhaps weren't getting the greatest service and experience. So not that out. But now what we're doing, we're about 8-9 months into the pilot project, is actually mapping the pathway as to where we wanted to be and where we were, to see, obviously to demonstrate that we are making an impact and having outcomes. It's still early days because obviously this patient cohort could return to ED at a longer period than what we're working in, but we're in early days. But data has been key, and I think that's the benefit of myself from finance and myself bringing in other finance colleagues into the mix with different skill sets to understand how the data goes, but how we present it, because quite often finding that correlation between some of the data is a skill set in its own right. And I don't think any one of us could go and present one set of data to get all the evidence and that justification why we need to do something different. So I shall pause there because I'm conscious. Is there any comments? Okay,
so what Karen is basically saying is that although there may be a proven service elsewhere, we got to demonstrate how it applies to our locality. And in terms of, I know once the project is started, patient improvement project or whatever, how do you sustain the funding for the project?
Right, the sustaining of the funding, because it was short-term funding, we're gathering now all the evidence and the data, as I say, between the baseline, the proposed, where we thought we would be by having the service, and then where we actually are. So that is powerful. Data is powerful. You can't hide from the black and white data, really is hard. So that's now where we're starting to really put a case to make this case permanent.
Now, the key thing about funding is now we most of our funding are based on short-term contracts, because this is not the main thing we have to know about this, because we're coming from professional funding. So because of that, there's no why is it always a recurrent one? Because the staff retention is very difficult. You know these things, right? To say.
Yeah.
And the other thing is sometimes we waste a lot of money because of that. Now, because Alison knows, she's my nurse. We've been asking. I put a business case last year for an extra doctor, so I'm sure you all must have had so many clinicians coming for an extra doctor. We thought, I can understand you completely right. The data I put it's in another scale. Me, I'm a clinician. I don't know anything about it, so I am learning from this work. And the other thing is we are providing locum doctors to come, and when we have a crisis point, they provide us a locum. Now again we have a crisis. We have given a 3 months locum. We are paying them every hour. I mean, I was trying to tell them, if you do a permanent funding, you don't save so much, but why is it not being recognized?
It's a good point. And we were discussing the same at the beginning of this.
Yeah.
You want to tell them about what is establishment funding and what is current funding and how to
think about these things.
It is.
I wrote to the medical director, James, as well, why this is happening.
Mm. And it is valid and it will happen. It's a finite resource, and it's getting restricted, and it's going to get harder the next couple of years. There's no two ways about it. But of the funding that NHS Wales gets, we've got to make sure, and I think we've all got that obligation to make sure we're using it correctly. Sometimes it's not about more money, it's about doing things differently, but we need to demonstrate that, and it's the evidence. So are we doing things, whether it's in your area or other areas, that we shouldn't be doing, but we've always done it. So it's about being a bit more creative and thinking about doing things differently. With this FLS system, it wasn't about medic staff, because they knew a nurse could do that, and all respect certainly there, but it's a cheaper resource. So it's about using that resource differently. So, but then when you're putting your needs forward in terms of need for an additional, more costly consultant to do this job, it's making everybody else. But it is all about evidence, and I do feel we need to have perhaps that leap of faith.
Yeah, the thing is, yes, you're right. That's why we have so many nurses as in my team compared to doctors. And the question James Calvert was asking about nurse consultants, because we have a problem of getting doctors. But the thing is, the governance structure is, because I'm working in the community, because governance structure needs to be sorted out first before you appoint a nurse consultant for a doctor. I was so many times again, previous medical directors coming to me personally asking when I didn't have a problem, I had 2 problems with doctors, why a physician associate let me do that job. So I was firmly said no. But one of my other colleagues, different, did listen to them and got a PA, and then he only stayed for a year or 2 and went. Yeah, I understand. It's just, I don't know, I'm totally confused.
Yeah, there's no easy solutions for this, but I think one of the things that has helped is what is called as benchmarking. So you got to benchmark your service and demonstrate that the basic need, you have to it's a painstaking exercise, but if you have a friendly finance person like Karen,
Because I thought I was benchmarking, but it looks like I don't know how to do it properly.
yeah, I think so. But it's not, there's no right or wrong way. I think you got to work through it to make the right pitch for it.
Yeah, but it has to be done collaboratively. Yes.
Hi, I just wanted to add, sorry, I'm Lauren from the World Osteoporosis Society, and your point around data is really important. And so just to say, they do have a facility to help you build a case in terms of what your population should, what you should be seeing, the benefit, financial benefits, and also the bed savings and that sort of thing. So it's a good place to start. But I was really interested in your role as business partner, taking that data and helping to present a really strong business case.
Yeah, well, it's been invaluable in terms of this scheme, because as passionate and as energized as Dr. Singh is in this topic, it was about how do we navigate the wider governance system of a very complex health board. Yeah, thank you.
Based on where I am. So I just started in this FLS role coming from practice. So I've come in and had a little look at what's being done currently, which the role was introduced in November 21. That was when they first had CNS appointed. So at the moment, I'm sort of looking at how we identify gaps in the service, things we potentially need to cover that we're not covering, and looking at how we sort of present that and get things like funding from nurses to move the service forward. So I've brought along with me today, I don't know how familiar, a lot of different professionals here. So anybody familiar with the FLS database? Yeah. So you've seen all the graphs and things. I won't hand them around. So looking at the graphs specifically from Iron Bevan, when the first nurse was appointed, things sort of improved on the data side. That is sort of quite encouraging that it's a good role. So at the moment, we've got patients come through to us on a weekly report from radiology. So any patients that have had a fracture identified, or it also picks up patients that haven't fractured. Fracture is one of the key words. So they will come through to us. They are then assessed and then popped on the database when we confirm that the patients have a fracture, and then they start their FLS journey from there. So at the moment, there's a denosumab service, which my colleague has set up, which is a great service. And we're hoping to sort of do something similar, but for these allogeneic patients. So it's just about how we identify them initially, arrange for them to have their treatment. So looking at sort of the logistics around that as well, sort of from my perspective. So at the moment, it's a little bit tricky with how patients are given their allogeneic. It's not sort of streamlined within the service. So we're looking at having sort of a dedicated area and clinic to be able to give these patients their Zol and follow them up. Is it? Oh, lovely. Okay, yeah, that would be great to share. So because I'm sort of fairly new, I'm coming as well.
In your community, are the GPs happy to take the responsibility?
Yeah. After the first dose of denosumab, they do the
IV is all in the community. Yeah.
So is that in a nurse-led?
It's prescribed prevention by the physician.
Yeah.
We don't have ICs yet. And remember, Again, I'm sorry, I'm talking to you.
No, no, it's fine. It's good.
Just one part of the huge other things.
Yeah.
We do blood transfusion, we do, and this is just one part.
So you're not FLS specific? No, it's
No, that's
part
what
of
I'm
your.
saying.
Yeah.
We identify as problem, but we found our own solution, got together all this, and we are doing it for them. Then when I hear this, that you're taking these things from me, so we already been doing it already, this is coming in the community.
So I think at the moment it's AMPs that are delivering it in YWF. It's about how can we.
Still, what I would say to you is take some time.
So, are you community based? Yeah.
It's not just patient experience, but it doesn't
Okay.
So, Dr. Esmond, probably a lot of prescribes the medication when you identify a lot of patients with I think that is really the
yeah.
So that pathway is in place, but they're identified maybe first in the clinic for we have our recall system in place.
Okay.
Recalls patients after every 12 months. So they have to fit a certain criteria. They have to have a clinical person score of 6 or below, because they have to be active and fitting well to be able to come in for treatment. Because at the moment we're unable to give insulin in the community because we haven't put enough research into it yet.
In the community, in the sense in nursing homes.
Yes.
But
Yeah.
what I'm trying to say, what I wrote, I'm the one who wrote the Southern Cancer under the governance of us in the community, not under secondary care. So they have a part to it. When the patient comes, how to give the Southern Cancer, when to do the blood, what other things you need to replace. So that is the community, and all the patients go to you maybe falling by year.
Yeah.
That is different. This is our team in the community. So that's where
That's something that we want to develop for the patients that are coming through and are identified by us.
White patients, you can refer to us.
Yeah.
But the problem is that they're struggling.
Yeah. So I think it's how we need to think about how we're going to sort of work with you guys as well in Torn Points. That would be great to sort of link up. I think the difficulty at the moment for sort of our areas is it's going to CRT referrals.
They are to run CRT.
They're talking about CRT.
This is your team.
Yeah.
That's what we are doing.
So it's how we can sort of work together. So I'm new in post, I'm into the area. So it's
the GP is responsible or consultant is responsible? Consultant.
We've got a in the community.
Yeah, my role. Yeah, my role is the rapid response to look at the medical problems. In the community. I have an activity which she leads the nursing bit.
Yeah.
But because we came to this lovely unit, which we have a clinic area where we've been asked to now produce stuff. So I had to develop some way of bringing patients to that under my governance. So that's how it all started. But we do it now.
So it's a sort of a day hospital in the community.
In classroom.
I think in terms of it historically, there were 4 services and that services were developed over time to develop that. And then obviously some services have developed in one way or the outpatient setting. And I think as a health board, there is a woman Falls and Frailty and support, and obviously it's about we need to get the best services together during that. Because otherwise it's all separate. We've got that's the clean structure in the health streamline. It's about bringing them together so it's aligned with what everybody needs.
Our side, day hospitals, they are very good. They manage automatically. They recall my patients for 3 years. So I don't have any problem.
I think it was because we are working inside.
But if there's something that we need to do to help kind of bring the picture, then if we can relieve that pressure, if it's a nurse clinic, and depending on the
Yeah, we only want to clinic once a week.
But if we can set up another one,
we have consultancies.
Yeah.
We're more than welcome to come down.
Yeah, that
we
would
are
be great.
quite open up as well. That's the first thing you see. Because your system is different. We might get different patients for this native area patient is from. They've been referred to the nursing. So we've had 2 of our patients referred into Wi-Fi treatment. And there's been an open.
Can I one thing because I have my own falls consultant as well.
Okay.
Because when I see patients, when there's fragility fractures, and when I recognize that, and I get specialist opinions from our during to give the infusion start the infusion. But then he wants me to continue that for the next 3 years. But I have a acute interaction with him right now. So I said, no, I can't take those patients. He said, no, but I haven't seen the patients. So we always have this, we haven't agreed about it yet. So I think you have to come between us and try to sort out.
And that's something that would be really good to do, to say, actually, these patients have got all, they'll come under
We're very close colleagues. We disagree in this, and we actually
but that's something good to know for me as well, something new, so we can swap details and chat, and it might be something we can do together.
Because they're trapped in between them and
Did anyone have other questions?
About this FLS database, so you submit or some admin person does it?
So initially it was nurse starting inputting the data. That's now changed in recognition that we can use the time elsewhere, nursing time. So now that's done by one of the
admin person.
that have been sort of trained with the
Another question, don't you are doubling up the problem, like NHFD, somebody is already putting the hip fracture data, and FLS database, you're putting the same hip fracture data, or it is?
So the hip fractures are going into the FLS.
Yes, so you are doubling your workload, isn't it? So some senior people, Anthony and other people might need to come up with some ideas, because hip fracture data, NHFD is fantastic.
Yeah.
They are putting the data, every bone health data is there.
Yes.
So whole data of hip fracture is already there. So why you are doubling your resources unnecessarily for FLS database? I know it was started in Oxford, but I think between Anthony and Oxford, they need to find a solution.
Yeah, I agree, because it is doubling,
doubling
and
of
actually,
the effort for no reason.
yeah, and we can spend that time with the other fragility fractures, because
you can spend your
the
time with
hips
the
have already
non-hips.
had their.
So FLS database should be non-hips.
Yeah, I agree. Any other questions? So at the moment, no. So if we're needing some input, it's referrals at the moment. So, but that is definitely something that would be useful. Is that yeah, and we can signpost them to a service. Yeah, I think.
And that's time.
No, but I think going forward that would be a really good thing to have.
We have one more move today for the next workshop.
Thank you. Thank you.
Yeah, carry on. Great.
Hi and welcome to your last workshop, I think it is. So just we'll do some introductions to start with. I'm Ali Doyle. I'm a nurse by background, and I've worked in trauma, metabolic services, ran osteoporosis and FLS services. I now still a nurse and I work for UCB Pharma, and my role is non-promotional, and I support quality improvement programs within the NHS out worldwide, really. So I've got experience of how different services are, but I'm based in the UK and Ireland, and just in terms of what UCP can offer, we've developed a clinical community of practice, which is a European network, which is called FLS Academy Network, or FAM. And what we're looking at doing is bringing that more locally to have a mini FAM for UK and Ireland, and within that, Wales can have its own house in this clinical community, and we can give each of the teams a room if they want to, and in those rooms we'll have quality improvement tools that we've developed with Professor Andy Gray, who's an orthopaedic surgeon, and he's in the Fragility Fracture Network, and with Professor Kasim Jubaid, who runs the FLSDB for the Royal College of Physicians. So during the breaks, I'll be playing a 6-minute video, and we have a launch meeting on the 17th of November if you're interested to come and talk to me a little bit more about it.
I'm an orthogeriatrician based in Cardiff, so I work within a physio orthopedic service, so inpatient orthopedic service, where we do in-house all the fracture liaison for the inpatient side of things, so secondary prevention and bone treatments, and manage that bit. So I have an inpatient view, so easily identifiable patients in Cardiff. As you know, our sort of outpatient and primary care stuff is run much more with Mike Stone through the metabolic bone clinic and doing those bits. So just having a slightly different view. I also chair the network of orthogeriatrics in Wales and work with WOAG, which is the Welsh Osteoporosis Advisory Group. So sort of having networks and an idea of what's available for sharing information, helping each other around Wales, which I think is important, which ties in with what Ali's doing with the academy.
So I don't know if you've got this, but it's a workshop, so it's participatory. So we need you guys to talk to us and tell us a bit more about what issues, barriers, challenges that you're coming up against. Do any of you work in FLS services? How are they doing? Any issues you want to talk about?
I'm not part of the FLS service, you know that.
I think
I think we should now. I realize it because we need to, because we identify. We identify. I work in the community.
Right.
I'm a community geriatrician. My specialty is frailty. So what happens is now a lot of patients fall and they are not very unwell to go to hospital, and they're triaged by paramedics now, and they refer patients to us, and Ben is here to talk about that. So we link and we have developed a pathway with that. So then we see these patients with fragility fractures, and we, as I said before, we work in silos, and I have linked with orthogeriatrician Dr. Usman, and I give the details. I email him, he looked at it, and then yes, Priya, okay, start. Or sometimes we do the FRAXPO and decide, okay, this patient is not suitable. And then Alison is our nurse lead who leads the bone health treatment, because we started it because we have a unit there. We thought it's ideal.
Yeah.
So now, as I've said so many times now, they are very busy and they're non-data, and this is part of my main job, being a community geriatrician.
Yeah.
And they need help.
Okay.
I think we need to be linking with the FLS, be part of FLS, and then sometimes we don't know where to, after doing an X-ray, when you identify who are the people I need to refer, and how to refer, and how acute this problem is. Because sometimes when I look at the fragility, I email spinal surgeons to look at it and see whether they need braces because they're in so much in pain. And sometimes they don't complain of pain, but then I see it in an X-ray. I said, oh, okay, fine, we'll just treat osteoporosis. You know, we are doing our own this thing, but we don't have
as you say, you're the people who need to decide and tell, okay, no, I think this patient needs this treatment.
Yeah, it's bringing all those together. So there's a lot of people doing a lot of stuff, and Fracture Liaison overreaches all of those areas. You know, so you've got rheumatologists, orthogeriatricians, community, and there's different areas that bring it together and understanding how they work. There's also, you say we need to start an FLS. There's a lot of this already going on that needs bringing together, and it has a label and doing those bits. But we realise how hard if we have those discussions that all of the inpatients, we have an inpatient fracture liaison service. We're not updating, and our issue is uploading data to the FLSDB, which we need to look at, but we monitor through the NHFD. So bringing that together and having those discussions of trying to take a step back and see who's actually doing what. There's a lot going on. This isn't a sort of a big thing to start in one massive go. It's chipping away at those bits and bringing together what you've got and then building on what you have.
Because Anthony said recently in your area, there were 2,000 patients who have fragile Europe who needs picking up. Actually, I think we are picking it up, but nobody's identifying it because we are doing it our own way.
And I think I know my other issue, so I do a lot of the boards entities in the community. So I do all their fracks and do all the bone health and start them on things is the follow-up, because I literally start them on it.
Yeah.
And sometimes I did go through a period where I was managing to fit in to email the FLS to say, we've started this, can you do a follow-up? But either way, that's a bit ad hoc depending on the team's workload.
Yeah.
Because they don't sit with us in the community, they're in a different building. And
Resource and admin, the common thing.
Yeah. I think what you said is really interesting, that actually there are different teams delivering bone health services. The fact that you're not called an FLS doesn't mean you're not doing bone health assessments and starting patients on treatments. And actually what I'm hearing is your patient journey right? So are you seeing the right patient by the right team at the right time? And then it's because it's fine that, you know, that Falls might do it. It's fine that, or the geriatricians might do it. It's fine that FLS service or OSP services do it. But actually it's that, how does that translate to who sees who best, and actually pulling all your resources together and then recording that you've had those assessments and that they come as a big team. You're one team, but you see different patients at different
and
times.
the other thing is we have to put the patient at the center.
Absolutely.
Because what happens is most of the time the patient likes to come to us, who works in the community and then can go home, then going to fracture clinic or going to hospital to sort out
or India refers his nurses and patients to us, and we give IVs all in a nursing home.
And sharing that information. Mike Stone was here last
because
and
I
talked
think
about the
community
self-injection.
services are like us need to be recognized the importance of it, and there needs to, because my own colleagues didn't realize that we were giving bone health treatment in Malguni for the last 3 years in my own health board. No, it's not her fault because she started, but that information hasn't given it to her. So you can see my frustration.
But if you look at population level and you look at your health board and your population, and then you map who's doing what within the health board, you can then say, look at your patient and your different cohorts of patients. And then you can say, well, how does that work? How do the patients get into that system? And actually, what I would say is, and I know I've been saying this a lot today, and it's great that you've actually taken time out to be here today, but actually taking a pause, because you're all really busy, you've all got great intentions, you all keep going, but actually taking that time out to pause. And actually, I'm not going to say math, because when I was, it's like, please, not another process back in, I can't take one. But actually to look and say, well, what are you doing, who you see? And actually then it's actually looking at which patients are best in some sort. I'm sure there's patients in your services that will be better in other services. And it's then actually looking at how you identify the patients and how you get them to go through the right pathways. And then how you pull all that data together so you actually can then demonstrate the number of patients you're seeing, the patient experience and the clinical outcomes that you're getting from those services.
I think so, because for us, we most of the time is the front end, is the everything, and we need to get out of that. As soon as we say you need to go to front end to solve the problem, patients make an informed choice not to go. And they say, I don't care, I don't mind.
Yeah.
It is understanding that population, because I think
Yeah.
when you've got a very good community sort of geriatric type service, we've heard from West Wales where they've got a huge rural population and a very different challenge, but understanding how people are feeding into that, but it does need that communication from everybody and sort of identifying where things are going on and what they're doing, conversation with each other.
But I think taking it to that health board level and then actually saying, you know, understanding where patients' pathways are and their journey, and actually then how do you capture that and how does that get fed back?
And then the thing is with Grant, I don't know you all have heard, when it's completely changing now. The dynamics are changing hugely, massively. I'm working in my own team for 8 years, and I was telling Beth this morning, and the way Western Grange opened post-pandemic and the ambulance waiting time, you know, all these effects, how we can run the service, and yes, but it's very challenging, even though we can send it.
The service changes, but the patient is still the same. And using patient experience and patient journeys to drive change. And that's where the academy stuff comes, of giving help and support to be able to do that. Of, you know, what does this mean from the patient and where do they come? So you can change the service as much as you like, and or the health board service changes, but the patients still drive through the same way. And sort of having an idea of how they move through that is very powerful.
Yeah, absolutely. And actually taking that patient-centric approach, actually, and I think it's really interesting that you said that whilst you've been doing bone health, other colleagues in your same health board didn't know you were delivering bone health services.
That's what I found out.
Yeah, so, and this is why bringing people together is so important, because actually we don't know what we don't know. And actually pulling people together to then actually say, well, how do we, and I think it's not bad looking at new ways of working. And actually, you know, even the Glasgow, I mean, I'm sure they won't mind me sharing it, are not delivering the service as the first FLS services they set up. They are actually moving to new ways. They're looking at digital solutions. They're looking at how they use their nurse resource more effectively in a different way.
We might have
so
to say we could come to close in a minute time, please.
Seeing patients. So other places are changing as well. So my big advice would be take a pause, take some time out, get the right people in the room, and actually look at your patient journey, and then see how they're being served by different teams, and then look at how you could bring them teams together and actually make your patient pathway. It doesn't mean people stop what they're doing, but actually they might see more appropriate